Ladies and gentlemen, dear colleagues, thanks to the organizer for this wonderful occasion. First of all, I would like to bring my, actually on behalf of Petra Iäs and myself, pass on greetings from our Department of Neurology in Helsinki. We subserve the same area as Professor Aalbeck told you about. I think it's even a bit more than 1.2 million. And we have developed a strong profile, especially in vascular neurology and acute stroke. We have around about 2,000 stroke patients per year, 1,600 ischemic strokes, and we thrombolize more than 300 strokes per year. And I think we still have the record time for door-to-needle time. The median is 18 minutes right now. So, and we have a good collaboration with vascular surgeons. We are really proud and happy about that. But this time we should be talking briefly about hyperperfusion syndrome. How do you advance the slides? Good. As we know, you cannot possibly overestimate the role of carotid arteries in the cerebral circulation. First of all, I would like to introduce a patient, 62-year-old man, previously healthy, but really heavy smoker, smoking as a chimney. And he had a few monocular visual loss attacks from left eye, and ended up in investigations. This was 14 years ago, so he underwent digital subtraction angiography, and he was found to have an occlusion on the left side and a 90% stenosis on the right side. And then he ended up in endarterectomy. So it's clear that he was an asymptomatic patient, but at the time, as you know, the practice was more liberal. He was discharged 4 days after the operation. He was fairly well, but had mild headache. And he was living alone. He was seen in fairly good state of health on the 6th day, but the day after, he was found at home in his apartment, lying on the floor, and he had seizures when the ambulance personnel was there. He was taken to the ER, where he had dense left-sided hemiplegia, rightward gaze deviation, and some hypertension. And this is the CT scan at that stage. So this is clearly hyperperfusion syndrome. And in this image, you see some perfusion images. On the left side, you see a perfusion image before the operation. The bolus is just entering the brain, and as you see, the dark area is at the back, so it's coming from the posterior circulation, and then partly from the right. And then after the operation, I wonder if I can show it here. You can see that the bolus is coming from the right side of the brain. And this is where he developed this unfortunate hemorrhage. What is this hyperperfusion? It's easy to understand that it's a blood flow increase that the brain tissue does not need. It's well above the metabolic demands of the tissue. And by definition, we have thought that the blood flow is increased more than 100% from the preoperative value, or the mean blood flow velocity in middle cerebral artery is more than doubled if you use TCD. So you may be using SPECT imaging, perfusion CT, or TCD, or near-infrared spectroscopy, whatever. And it's notable that this hyperperfusion can be asymptomatic, but in some patients, as we saw, it may become symptomatic. So some people talk about reperfusion syndrome. These criteria, doubling of the blood flow, is quite specific, but it's not very sensitive. And we clearly have some patients who do not fulfill this criteria, but they still develop reperfusion syndrome. So this is a suggestion that we might define reperfusion syndrome as a symptomatic redistribution of blood flow, as you saw in the previous perfusion scans. The triad consists of headache, almost invariably there. It may be pulsating on the same side as the operation, of course. It may be felt in the eye and on the face. And the patient may have neurological deficits on the contralateral side, and then seizures. And worst of all is the complication of hemorrhage. And those patients have a fairly poor prognosis, a very high morbidity. Actually, hyperperfusion after operation is fairly common. It's more than 1 out of 10 who have hyperperfusion that fulfills the criteria. But only about 1 out of those 10 are those who become symptomatic. And the case is quite similar after CEA and stenting. This is an old study from Japan. They were following up about 60 patients, and here you see that those who fulfilled the criteria of hyperperfusion, many of them returned back, so it was normalized, the situation, but all those patients who had hyperperfusion syndrome belonged to this group of patients who had more than double of the perfusion increase. Cerebral circulation has a very powerful autoregulation, and in these patients who have high-grade stenosis or poor collateralization, they may have exhausted all the reserves. So we may think that the capacitance vessels are wide open, and so they constrict poorly. The arteries are secreting more, say, carbon dioxide, nitrogen oxide, and so forth, and the vasoconstriction is poor right after the operation. And varying degrees of endothelial dysfunction is something that these patients surely have. Then we have all the mediators that belong to this reperfusion syndrome. We may have complement activation, permeability problems, and so forth. But what is the role of hypertension that seems to be present almost invariably? That's actually the most common factor found in these patients. And in a review of 44 cases of hyperperfusion syndrome, only 1 was normotensive at the beginning. So it's quite clear that this is an important factor. And what is good about it is that it's a modifiable factor in this cascade. So we may think that why the patient is prone to hyperperfusion is a combination of this chronic hypoperfusion. The patient has high-grade stenosis. Those who have poor collateralization have a higher risk. And then all the other aspects that pertain to arterial hypertension. A reminder, in real life, headache seems to be fairly common. This is a series that we made long ago in Helsinki. We followed up patients, more than 100 operations, and around about 40% seemed to have headache after the operation, and mostly mild to moderate. But those patients who developed neurological symptoms like confusion or seizures, they all had, they were the few hyperperfusion cases that we had, 3 altogether. So it will converge on antihypertensive treatment. This is a series of 3 centers, very high volume centers in the US, and they developed a protocol that aimed at having blood pressure under control before the operation, less than 140/90, and in high-risk patients, the blood pressure was to be even lower. They were using labetalol, beta-blocking agents, and nitroglycerine. And in the table, you see what happened. The incidence of intracerebral hemorrhage was 0 after implementation of this protocol. And actually, in the lower part of the table, you see that those patients who were deemed to be high-risk patients were the ones who really had the problems. But they were able to cut down the incidence by applying this protocol. Another high-volume center in Leicester, UK, has a bit simpler protocol that's been published recently. They also have cut down to some extent. This is not statistically significant, but a good trend. How we try to prevent hyperperfusion in Finland. We try to keep postoperative blood pressure in all patients under control, hopefully. In high risk patients, lower in the same way as in these US centers. If the patient has symptoms that could pertain to hyperperfusion, the patients all should undergo emergent brain CT and then primarily TCD. You may also use perfusion CT or even perfusion MRI if you wish. And these patients should be monitored. They can't stay on the ordinary ward. And those patients who have hyperperfusion are immobilized, and blood pressure is aggressively lowered. But we have to keep in mind that these patients are also high-risk patients in terms of low blood pressure. So they really need the surveillance. So, by way of conclusion, hyperperfusion is not uncommon after these operations. Hyperperfusion syndrome itself is fairly rare, but it's a very significant complication with high morbidity. And although we don't fully know the pathophysiology of this, we can reasonably well identify the patients who are at high risk. And we can do something about that primarily by following a strict regimen with blood pressure control. Thank you.